Hey everyone, glad to see lots of familiar faces. So today I'm actually going to talk about behavioral interventions for substance use disorder treatment. So I'm going to share my screen and get this kind of going here. And I'm going to focus on modalities as well as models for those of you who have the capacity to have different kinds of modalities in treatment interventions. So I'm going to start by asking actually for a little audience participation right at the beginning here. People are feeling alert at the end of the day. So I'm social work faculty here in the Department of Behavioral Medicine and have been working in the COAT program since its inception. I don't know how many years ago, 16 years ago or so. And, the model has evolved and the kinds of therapeutic interventions we use in COAT has also evolved, which I'll talk a little bit about. So we'll talk about why, psychosocial interventions as opposed to just medication a little bit, and then we'll talk about treatment modalities. So by modalities, I mean individual, group, family, couples, those kinds of modalities, and then evidence-based models that are effective with individuals with substance use disorders, and then some specific models we use in the COAT program. So these are kind of the general modalities that I think of: individual, group, family, couples, and then there's actually a modality that's multi-family group therapy, where you have multiple family members from individuals all in one group together, which is what we do in our IOP program. But just thinking about when you guys, how do people in programs make choices about what kinds of modalities to offer any given individual? Sometimes we make that based on like, this is how the program works. But when you have a choice, like how do you choose whether to have someone in individual therapy, family therapy, couples therapy, or group? How do people do that in their programs?
Don't be shy, unmute or raise hand feature. Don't leave Laura hanging.
Otherwise I have to call on people. So Derek, what do you think?
I think that's a technique we call spotlighting. We kind of like if a client asks for it, we'll definitely, if it's something we can't offer, like family couples therapy, we can do that. But there have been times where, based on what a client might share with us about their home life or social situations, significant others, whoever is involved, we would recommend coming in for family or couples counseling to also come up with like, the old school crisis plan or a relapse prevention plan, and how family members or loved ones can be involved, but also just kind of help strengthen their social supports. So there have been times where we've had said, hey, would you like to get your partner involved in this, and have them come in?
Yeah, is there like a clinical scenario that comes to mind where you might like ask the patient if they'd be willing to bring a family member in? Like, what's a situation where you might do that?
Well, if it's a situation of a live-in partner who is also if they're in active addiction, that's certainly we want to try and get some kind of involvement. If they're also in recovery, we know that two different people working, especially early recovery, living together or in a relationship, can be a lot to try and manage. So kind of helping them figure out how to work with each other. But if there's any kind of children involved, we definitely try to get family therapy involved with that.
Great. Thank you very much, Derek. I appreciate it. Anyone else kind of have thoughts on this or want to share their genuine, like the general way of employing different modalities?
I was just going to say, pharmacologically, it's nice to have family involved if you're having a patient take antabuse, because they can witness the patient take the medication. And also when family members are enabling addiction and that kind of behavior, you have to intervene with the family to stop that, or the addiction will persist.
Absolutely. Absolutely. Those are great examples. The other one is sometimes if a family really does not support medication-assisted treatment and is shaming the client or negating, their recovery because they're on medication, that's another thing that has come up. Any other examples?
Going to say I second Hirschler's thing about patients and families and medications. And last time we talked a lot about amphetamines, but also in terms of using stimulants for people with amphetamines, which is a very kind of dicey subject. But recently, some of the people that I have given it to, they've actually volunteered their families to also monitor them with that. So if you have concerns with certain medicines, but the family's, good family, and can monitor it, consider using them too. And maybe if they don't really trust the way that Suboxone's used or whatever med, it's not the worst thing in the world to have a family member see somebody taking it. So if it helps them buy into it, then I say go for it.
Thank you.
So I have a question about that. Mm-hmm. This is really interesting because I don't know how much in our program we do family or couples. But anyway, so if you're engaging the family to assist with the medication, what does that look like in terms of family therapy? I mean, do you have one session or some sessions, or can you guys talk a little bit more about what that looks like?
I'd be happy to say something about that. So there's something called network therapy, developed by Mark Gallanter, where they do things like have family members involved with antabuse, and what you would have several sessions with the family members and for kind of follow up, how is it progressing? So not only just initiate the process, but then follow up and see how are things going and kind of see if you can get some progress moving along. So it could be 2 or 3 sessions or even more. And then other things like getting them to AA meetings and their medical appointments, and can all facilitate the process of recovery.
Yeah, I mean, I'll say it's important to have the patient buy-in. So you don't want to do this against the patient wishes. So kind of just to put that out there. So the patient needs to agree to have family involved typically, and then be part of the decision-making process about what's helpful and what's not helpful. And sometimes during the course of treatment, that may change. And so doing some psychoeducation around addiction and treatment is usually one of those foundational meetings that Dr. Hirschler is talking about in the beginning. And then maybe as treatment changes, like having another session, 3 months later or something. And as the person regains trust and regains independence, sometimes it's important to let the family member know that backing off a little bit and handing over some of the responsibility to the patient can actually be very effective, because there's a lot of fear with family members about their loved one, overdosing and dying, and sometimes that makes them hold on pretty tight. We have a multifamily group as part of IOP, which is just kind of an old school model. So literally patients all come to group, and then they can invite family members, really as many as they want to. The most we've had is one person had 4 family members there. That was a lot. But it's really impactful for the whole group to see other people interact with their family members. So even if people don't bring a family member, they see other people interacting with their family members. They see what goes well, they see what's possible, they see maybe what doesn't go well. And it really gets them thinking about the impact of their addiction on their family members. And so it can be really powerful modality. you do want to make sure you have folks trained in couples or family therapy who are doing the interventions. Okay, and the reason is really because, you know, we think of, or I conceptualize treatment as a biopsychosocial and perhaps spiritual model. So it's not just about taking a medication and getting well. And in fact, addiction occurs in a context, often in a family context or in a social context. And so involving other pieces of the person's life is often extremely important for treatment to be effective. There are sometimes facilitators in the environment, the social environment, and there's sometimes you know, barriers in the environment to wellness. So we're going to go through the evidence-based treatments for substance use disorders. Many of these you guys are familiar with, so this may be a review for folks. And then I'll talk a little bit about how we've adapted these specifically for our MAT program. So this is just kind of a list. These are all have had extensive research behind them. And this is kind of the general list. There's actually been an adaptation of dialectical behavioral therapy specifically for individuals with substance use disorder. So that is a relatively new model. And then you guys may be familiar with some of the yoga and mindfulness-based practices. And then a couple of others are the matrix model, which has been approved for treatment of stimulant use disorder, which you may be familiar with from Rick Rawson. He's done a lot of trainings on that. And then physical exercises is yielding some promising evidence. So just foundationally, CBT, most people are familiar with CBT. It's very problem-focused and action-oriented. And the idea that there's kind of three components of emotions and that we can intervene in changing emotions by either changing our thoughts, changing our behaviors, or changing how we feel physically, which is triggering an emotion. Lots and lots of research on CBT as an evidence-based treatment for substance use disorders. And it's thought of as very collaborative, which is, I think, lends itself well to like a group setting. It's very active and behavioral, based on open-ended questions. It's also pretty structured and present-focused, which is consistent with, say, 12-step models or substance use treatment in general. And again, can be individual or group-based. So the other thing that's nice, and I'll talk a little bit about relapse prevention, but it really helps with the relapse prevention piece. So if someone comes into your office and they've disclosed a reoccurrence or a relapse, you can really help them process what happens. Because sometimes people will say, I have no idea what happened. All of a sudden, you know, I find myself using my drug of choice or at the bar, or, you know, and they just have no idea how they got there. When in fact, there's a whole process that occurs before someone ends up picking up their substance of choice. And this helps break it down. So you look at the activating event, but also the beliefs and thoughts and attitudes and assumptions, motivations that may have begun weeks or months before the person actually picked up, and then the consequences, feelings and emotions that occurred after, which can help people motivate to do it differently next time. You guys should be familiar with contingency management, as lots of you have gotten training on this. And I learned recently, I can't remember if it was ECHO or one of our MAT meetings, that many of you have instituted and implemented contingency management programs, which was awesome to hear, and has shown to be very effective with stimulant use disorder. So the kind of the basic principles are monitoring target behaviors, having behaviors be very specific, providing an incentive for engaging in that behavior, and then rewarding that behavior as immediately as possible following the behavior, or not rewarding it if it does not occur. Community reinforcement is another approach. This is a little bit more difficult to do because it really requires a very large team and incorporates other evidence-based treatments like motivational enhancement or motivational interviewing, as well as contingency management, which is basically the voucher-based reinforcement program. There's also like job counseling, relapse prevention, marital therapy. So this is really an all-encompassing kind of approach. And if you work in a setting that has the ability to provide all of these services, it's a great program. Most places do not have the ability to provide all of these services, but it does speak to the biopsychosocial conceptualization of addiction, in that their interventions in all kinds of areas of people's lives are actually what produces long-lasting recovery. So a little bit about relapse prevention. So Terence Gorski is kind of the grandfather of relapse prevention, and it does incorporate CBT strategies. So that chain analysis is what I was referring to when you go back in time and say, well, actually, what happened like the day before you actually picked up, and then a few days before that, and then the week before that, and people can begin to see patterns of relapse, and also warning signs of relapse, whether those be attitudes that change, behaviors that change, or kind of moods that impact the relapse process. And then people, places, and things. Obviously, this is fairly common language that we use in terms of helping people understand their triggers and their relapse risks. It's also very helpful to have a written relapse prevention plan. This is a little bit old school, and we've gotten away from that, but it can be helpful. This would typically be done in individual therapy, but it can be done in a group. And also specifically a relapse prevention plan if someone's going into a high-risk situation. So if someone is going to an event that they want to go to, or that they have to go to, like a wedding, where they know there are going to be substances, having a relapse prevention plan specifically for that event can be very, very helpful. So 12-step facilitation is another evidence-based treatment that came out of the work in the 90s, and it's a manualized treatment, and it really incorporates the kind of primary strategies utilized in 12-step recovery, which are accept and surrender and getting active in treatment. So those are specific kind of modules that are part of 12-step facilitation, and it's usually in a group setting. The model is group-based. And then DBT, which many of you guys are familiar with, again, has a specific adaptation called DBT-SUD. And the model uses some community reinforcement strategies, as well as building social supports for recovery, and some behavioral components around people getting more comfortable in abstinence, because oftentimes people describe feeling uncomfortable in their own skin, and then that's very difficult to maintain abstinence when people can't tolerate the feelings that come up for them when they are abstinent. And this can be helpful with people with co-occurring mental health disorders. Motivational interviewing, again, is not technically a model, but a way of interacting with people and with talking with people, so as to promote change talk and reinforce change talk, so that people gain some hope and also gain an ability to imagine a life of abstinence, which often is what prevents people from coming into treatment, is like they literally cannot imagine living their life without substances. And so motivational interviewing can be very helpful in helping them begin to imagine that. The main skills of motivational interviewing are reflective listening, affirmations, open-ended questions, summarizing, change talk, sustaining talk, so sustaining change talk. And generally you avoid confronting, which with some patients who can be challenging of us as providers, or can be difficult in group settings, this can be a helpful skill. There are several mindfulness-based interventions, so mindfulness-based relapse prevention, mindfulness-oriented recovery enhancement, the acronym is MORE, and then acceptance and commitment therapy also has mindfulness-based components and DBT as well. So mindfulness-oriented recovery enhancement has shown actually really good outcomes with individuals with both opioid use disorder and pain. And Eric Garland is he's actually a social worker who developed that intervention. And again, shown to be helpful with individuals with co-occurring mental health and substance use disorders. The matrix model, and I show the pictures here because this is downloadable. It's a treatment manual you can download from SAMHSA for free. And it's a little bit like the other model we talked about that has multiple, that utilizes really multiple evidence-based treatments in one. So 12-step facilitation is kind of in here, motivational interviewing is in here, inclusion of family and CBT strategies. So what does this look like in the COAT program? So I would say the groups that we run in COAT are fairly CBT based, although we certainly, depending on the therapist and their particular theoretical background that they're most comfortable with or trained in, they might incorporate other strategies such as DBT, but pretty CBT based. And so one example is we teach people how to identify and avoid triggers that lead to use, and then how to address emotions that come up that lead to cravings, or emotions that come up that make people extremely uncomfortable and engage in behaviors that are not healthy. So we talk about coping strategies. So we teach people coping strategies. And then many of you, and we've also incorporated contingency management into COAT. The behaviors that we have identified that typically we want to reward with an incentive are attendance in treatment, negative urine drug screens, and sometimes attending individual therapy or different kinds of attendance based on the program that's being implemented. The goal is really to retain people in treatment and to reduce substance use by giving small incentives. And again, as simple as possible, and the incentive to follow behavior as immediately as possible. And then these are also some core group content that we typically discuss. When we started to share the COAT model with other providers around the state, we surveyed all of our therapists and asked them what they talk about in group, and it really covered these general content areas. Now you might cover more of one thing, say in a weekly group, and more of another kind of thing in a biweekly or a monthly group. So when you get into kind of the middle phases of recovery, people are typically looking at relationship stuff. Versus early on, people are pretty focused on coping strategies. But teaching about the disease model and neurobiology of addiction, helping to reduce guilt and shame through that teaching is really one of the helpful things about teaching people about their brains and their brains in response to substances. Relapse prevention, talking about the stages of change and how people move through the stages of change, and it doesn't always go in one direction. Some people go backwards in the stages of change, and also skill acquisition. What do skills look like? What are coping skills? We use that word, but I think sometimes patients have no idea what we're talking about when we're talking about coping skills. And so getting very concrete about what we mean by that, and even practicing the skills. So practicing interpersonal coping skills. When someone in your group irritates you, we get to practice like interpersonal coping skills and really naming that as it unfolds in the milieu. Managing feelings is really important, especially in the early phases of treatment. People are often flooded with feelings that they have numbed for very many years. And so feeling their feelings is incredibly uncomfortable, especially as it relates to trauma. So people not only have kind of emotional feelings, but physical feelings in their bodies that they are not used to feeling, which may trigger some traumatic memories. Interpersonal and family relationships. Sometimes we don't really get to this until the biweekly phase of treatment. So the impact of substance use on the family, how to set boundaries, how to repair relationships that have been damaged if possible. And then really developing sober social supports. And so that covers generally the models and modalities.
Thank you so much, Laura. Again, just a wonderful presentation, and your voice is so calming and soothing. I just love listening to you discuss things. Does anybody have any questions or comments or anything they want to add to this? We do have the time.
I wanted to bring up the issue of mindset. So I find with patients, for example, with stress, that they tend to view stress in a strictly negative way. And so their mindset can be adjusted to say, okay, stress is tough, but if you can get through something difficult, the next time you're exposed to something stressful, you're like, oh, that's not so bad. I've been through so much. And so you can change their mindset. And I think that's a really powerful thing to do with psychotherapy with patients in addictions.
Yeah, it makes, I always, so I think the struggle for patients is they've often stayed in such a high level of stress, they don't ever get the break. And so then when they get a break and the stress comes back, they think it's going to last forever. And so there's almost the sense that you can help people understand that it can come and go because they may not have really had that experience recently. So I think there's a piece around that, because sometimes my experience with patients is they get in a place of stress and they get overwhelmed because they think, oh my God, here we go again. This is going to last forever and I'm never going to be able to feel any different than this extreme way. But that's a good point. The idea of it coming and dealing with it, and then it subsides.
And I guess what I think with mindset is that I'm trying to facilitate a strong mindset, that the patients kind of feel vulnerable and weak, and if you can empower them, I think they feel more able to manage cravings and take care of themselves better.
Absolutely.
Well said. Thank you so much. Does anybody else have any comments or more they want to add to that, the mindset of patients and ourselves?
I second Dr. Hirschler's thing, and also I think it's good when things are going well to talk to people about, it's not always going to be well, and just because it's good right now doesn't mean something's going to not happen soon, and to kind of prepare for that mentally before it does happen. So the best time to intervene with stress is not when people are super stressed out, it's before they get stressed out. So talk about it, and because life is still life and things happen, the dog gets sick, the car breaks down, it's bad. A country music song, right? They're all bad country music, I'm just saying. Sorry about that. But the other thing I was going to say, no offense to anybody, we just got back from the ASAM conference. So a couple interesting things, because I think this is very relevant to code and to ECHO, is that for one, there's definitely a push to expand access to methadone, which I know makes some people nervous in a way, but I think is a wonderful thing. So if we have more access to other treatments, because not everybody's going to do well from methadone, from buprenorphine. So we need to have more access to methadone. So for those who don't know, there's a moratorium in the state. There's only 9 clinics by law for the legislator, and that hopefully will be changed soon. So that's important. So if you have anybody that any representatives, any senators, anybody you're close with, tell them you're definitely in favor of more methadone for people. The other thing from a governmental level, so the reason it is only clinics is that's a DEA thing. That's a government thing that's been around since the 70s. So there's actually a bill at the US Congress level to allow doctors to prescribe methadone through pharmacies, which would be great for addiction treatment. So it's quite possible that we could have expanded access to not only using buprenorphine in the future, but possibly even writing methadone out of code groups and stuff. So just something to think about. So maybe we'll start talking a little bit more about methadone in the days and weeks to come. So I look at all three kind of on equal plane. So we use bupe mainly, but for the right person, methadone or naltrexone. So just things to maybe keep an eye out for and look into, and we'll see what happens.
I had another thought. One thing that I really like to see in group therapy is when patients do well or they graduate from a group to a less intense level of care, it's nice to hear from them what helped, and how come they're better, because that is good information for the rest of the group to think, oh, maybe I could try that. If that works for them, maybe that's something I could try. So you can kind of learn from the successful people in a group.
And I don't know if we've shared here that we have sort of an informal mentorship program that I think our case manager, Lori Plum, and others, and Jeremy, I think this happens in your group, where our monthly people will come back and talk with our weekly folks in group and do kind of like a mini lead and share their story and how their lives have changed in recovery, which has been very well received by the groups, and also I think has also benefited the monthly patients who have participated in that. So that's been a terrific kind of evolution of the model.
That's really nice. Nice to hear that you guys do that. That's nice. Sorry. Does anybody else have any comments or stories? All right, you guys got some time back, and I'll just have one announcement, and then I'm going to take my crazy dog to like run her life away in energy. Next session is going to be on April 25th with Tony DiGiacchio, and she's going to be discussing West Virginia legislative updates regarding SUD treatments. So that'll be a really great one. Again, thank you, Laura, and thank you everyone for joining us today. Have a great day.
Thanks, everyone.